We are delighted to welcome you to our webinar today. Today we'll be discussing the recent RCT study as it relates to combining PGA-tested embryos with an endometrial receptivity analysis test, focusing on the indicated patient population. We're excited to present not only the science, but also share real-life experiences with you and answer any questions that you may have. Just as a reminder, please feel free to submit your questions throughout the presentation by typing them into the questions box located on your screen. We will reserve time at the end for discussion. But before we get started, I do want to take a moment to introduce myself and the other guests. My name is Lauren Hurst. I am a nurse and medical science liaison with iGenomics. I have a bachelor's degree in sociology from Wake Forest University and a bachelor's degree in nursing from the University of North Florida. I have over 9 years experience working with infertility patients in various nursing positions. As an IVF nurse and third-party coordinator, I have had the pleasure of assisting patients, egg donors, and intended parents with their fertility journey. I joined iGenomics in May of 2023 as an MSL in genetic services, supporting clinics and patients with their endometrial testing services. I am excited to introduce you as well to our first panelist, Dr. Aimee Eyvazzadeh. She graduated from UCLA School of Medicine and completed her residency in obstetrics and gynecology at Harvard Medical School. She also completed a fellowship in reproductive endocrinology and infertility and holds a master's in public health management and policy from the University of Michigan. Dr. Aimee is a full-time practicing fertility doctor and is beloved by patients and the media alike. Her focus is on finding the sweet spot of where science and patient care meet and empowering people to better understand their fertility. She launched Egg Freezing Party in 2014 to help educate people about their fertility preservation options. And since then, she's also launched the Egg Whisperer Show to further reach of how she educates people. It's broadcasted to YouTube, IGTV, Facebook, Twitter, and as a podcast with the same name. We also have Dr. Michael Glassner as the founding partner and medical director at Main Line Fertility with over 25 years experience in the industry. Dr. Glassner is both a scientist and a clinician, treating patients from across the globe. Recognized nationally for his expertise, Dr. Glassner has been named a Philadelphia Magazine Top Doctor for 18 consecutive years and a Mainline Today Magazine Top Doctor for 18 consecutive years, as well as a Castle Connolly Top Doctor for 19 years. An award-winning physician and pioneer in reproductive medicine, his prolific research has led to breakthroughs in infertility care, including the world's first pregnancy and live birth using early screening with next-generation sequencing. He is a frequent guest on national news programs and a trusted source for expert commentary in the field. Dr. Glassner considers himself born into his work as he is a product of a successful fertility treatment himself. His parents endured 5 years of infertility before his birth in the late 1950s. Dr. Glassner has a personal philosophy of always providing the most caring, personalized treatment for every patient. And last but finally not least, our very own Tiffany Stankiewicz. She earned her undergraduate degree in animal bioscience from the Pennsylvania State University and a PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling both for embryonic aneuploidy and endometrial receptivity using genetic testing. She has over 15 years of clinical laboratory experience and is a fully trained embryologist and is certified by the American Board of Bioanalysts in both embryology and andrology. Tiffany joined iGenomics in 2016, where today she serves as the Global Endometrium Product Director for iGenomics. With that, let's dive in. Please thank you and welcome Tiffany Stankiewicz.
Thank you, Lauren, for the introduction. We're going to go ahead and dive into just a quick background about ERA. So again, I'm presenting a scientific webinar, nearly doubled live birth rates with ERA for RIF patients. So as I start all of my presentations, I talk about implantation itself, which is a significant rate-limiting step in both human reproduction and IVF. At the very minimum, the equation for success is an optimal embryo and an optimal endometrium. However, when we consider cases of recurrent implantation failure, we need to dissect this equation even more, as it is imperative to find a solution for these patients. So looking at recurrent implantation failure, this affects approximately 10% of couples undergoing IVF, After the third failed cycle, there's been reported of 22 to 50% dropout rates with increasing tendency with each consecutive cycle. I think we can speak with experience of myself and the other panelists on this webinar. Patients are truly desperate to do something different and to effectively address and overcome their implantation failures. They really do want a solution. So with that said, introduced in 2011 with the objective to deliver a solution for patients suffering with recurrent implantation failure of endometrial origin, the ERA test, or endometrial receptivity analysis, is the world's first molecular assay used to determine each woman's unique personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. So looking at recent data, I want to show ERA why it's a proven solution for RIF. So let's start by defining what a proven solution means. And that's oftentimes we think of randomized controlled trials, or RCTs. These are the gold standard in evaluating the effects of treatment. But an important thing to mention is that to be clinically meaningful, results must be relevant to specific patient populations in specific settings. So I want to keep this in mind as we're going through the previous RCTs pertaining to ERA. Now, to date, there are 3 randomized controlled trials involving the ERA test. The first one was published by our group in 2020, Simone et al. The second by the Shady Grove Fertility Group in 2022, and more recently by Barbacazzi et al. In 2024. Now, what we need to keep in mind here, again, is what I mentioned. Results must be relevant to specific populations. So when we break down the populations in each of these RCTs, we see that Simone et al. Included good prognosis patients, not the indicated RIF. Now, in this initial RCT, since we had prospective trials showing the benefit of ERA in RIF, Simone et al. Set out to see if there was additional benefits for patients outside of the initial indicated population. So although we saw a significantly higher cumulative live birth rates, again, this was in good prognosis patients, not in RIF. Now, the work of Simone et al. Was furthered by Doyle et al. In 2022, who added an additional aspect to this study, and that was looking at euploid embryo transfers with ERA. But again, the patient population were good prognosis patients, so patients specifically without recurrent implantation failure. It wasn't until recently that we have an RCT by Barbacazzi et al. That was actually in the indicated population of RIF, and that is what we're going to go through today. So the RCT by Barbacazzi et al., the study aimed to improve ART outcomes with personalized embryo transfer according to endometrial receptivity analysis, or ERA, specifically in advanced age patients with challenging reproductive histories, with RIF, by utilizing donor oocytes with PGTA for embryo testing. Now, there were 3 study groups. The first one was the study group of patients 35 to 45 years old. These were AMA patients using donor eggs and PGTA along with ERA. Control group 1 was, again, advanced maternal age patients 35 to 45 using donor eggs plus PGTA, however, transferring at the standard time in a frozen embryo transfer. And then finally, control group 2. These were younger patients less than 35 years old using autologous eggs, but also using PGTA plus ERA, so similar to study group of AMAs. Now, looking at the comparison, we look at the advanced maternal age groups, so our study group versus control group 1. And again, the study group, let me get my pointer here. The study group used both PGTA and personalized embryo transfer guided by ERA versus the control group, which again was just PGTA only. And what the authors found was that pregnancy rate, implantation rate, and live birth rate were significantly higher when ERA was added to a PGTA cycle. So to summarize this, ERA nearly doubled the live birth rates when added to a PGTA cycle in the advanced maternal age group. Now, what happened when they compared the study group of advanced maternal age patients to the control group? So remember that both of these groups had PGTA plus ERA performed. And what they found was that the clinical outcome rates were similar between both of these groups. Hence, we see that ERA mitigates the effects of endometrial aging. Now, taking these results together, we can see that the groups that used ERA, both the AMA groups, indicated by the dark blue, and the younger patients, indicated by the light blue, all had statistically significantly better clinical outcomes versus those patients who used PGTA alone. And that was across the board, again, for pregnancy, implantation, and live birth rate. So the conclusions provided by the authors were that personalized embryo transfer guided by ERA significantly improves pregnancy, implantation, and live birth rates in patients with RIF, including those with advanced maternal age. Furthermore, with no significant difference in clinical rates between the study group and control group 2, using ERA with euploid embryo transfer overcomes poor reproductive outcomes associated with advanced maternal age, normalizing them to those achieved by younger patients. Now, I want to introduce a recent publication. This is from our group that was just published this past May. And why I wanted to bring this up is that we see that the results of the RCT were essentially reproduced in this more recent publication. Here, this was a retrospective review of patients who underwent PGTA. We had the same group, so PGTA plus ERA versus PGTA alone. And what we saw was significant increase in implantation rate, pregnancy rate, ongoing pregnancy rate, and live birth rate when ERA was added to the PGTA cycle. In fact, ERA increased the odds of ongoing pregnancy by nearly 3-fold. Now, considering both of these studies together, the recent retrospective study by our group, along with the RCT from 2024, again, we have similar study groups, PGTA alone versus PGTA plus ERA, and both studies showed a nearly doubling of live birth rates in the ERA plus PGTA groups. Now, beyond these two publications that I shared today, there are over 50 scientific publications supporting the role of personalized embryo transfer, specifically in patients with recurrent implantation failure. In fact, I invite you to our ERA Insight Hub, where you can receive this list of all the papers pertaining to ERA, both internal from iGenomics and more so independent papers published by clinics. But the question I receive in the field is, what about the publications questioning the clinical utility of ERA? And I don't think that this should be ignored. So I put the 5 most controversial ERA result papers here, and I want to explain why these are irrelevant. Starting with Tran et al. Well, this one's easy. As of October 30th, 2024, this paper that was published by Fertility and Sterility was retracted, which we'll go through in subsequent slides as to why. Casalino et al. By the EBRMA group, these were in good prognosis patients, not the indicated RIF population. Beyond that, there were several other biases that should not be ignored. Arian et al. By the Boston IVF group was a systematic review and meta-analysis specific to ERA. However, in addition to just focusing on good prognosis patients and not indicated RIF, the authors also considered a study by the ER-PEAK, which is not the ERA test. So that also needs to be a bias that should be considered. The Doyle et al. RCT, as we previously discussed, this was in good prognosis patients, not the indicated RIF population. And finally, Richter and Richter, which was an independent, by independent authors, an opinion piece published in Human Reproduction. This was a reanalysis of the Shady Grove Fertility ERA RCT results, which again were in good prognosis patients. Not to mention, there was misconceptions of how the test works by the authors, including several references to the Tran et al. Study, which is subsequently retracted. Now, looking at the retraction, again, I invite you to visit our ERA Insight Hub, where you can gain access to the retraction notice about this paper. But as I mentioned, it was a meta-analysis published in July 2022 by Fertility and Sterility with conclusions that claimed ERA showed no significant improvement in IVF outcomes, except for live birth rate in patients undergoing their first IVF cycle. But again, the ASRM Publication Committee and Editor-in-Chief of Fertility and Sterility officially retracted this publication on October 30th of 2024 following discovery of significant errors. And those errors are made to note in the resource you see here. Now, how can we ensure optimal results with ERA? So we only have the best outcomes for our patients. This is one theme when it comes to ERA that we push very hard, is to make sure you're following the protocol exactly. And one resource that we have for both clients, clinicians, and patients is our ERA Insight Hub, where you can find tools. Patients can register for endometrium pre and post testing webinars directly with Lauren. And then there's expert videos along with tips from our scientific advisors around the world. So conclusions: successful implantation is a rate limiting step to successful pregnancy in both human reproduction and IVF, and largely hinges on the optimal endometrium and an optimal embryo. RIF affects about 10% of the population, and patients affected by RIF are prone to drop out of IVF treatment and are eager to address their cause of implantation failure. The ERA test was the first commercially available test addressing RIF of endometrial origin, and randomized controlled trials are the gold standard in evaluating the effects of treatment. However, to be clinically meaningful, results must be relevant to specific patient populations in specific settings. The only RCT in RIF patients that test endometrial receptivity, specifically ERA, demonstrated significantly better reproductive outcomes for patients who use ERA plus PGTA versus PGTA alone. Furthermore, advanced maternal age RIF patients had similar clinical outcomes to younger RIF patients. ERA is the only commercially available endometrial receptivity test backed by RCT. And although controversial results have been published about ERA, it's important to thoroughly consider the study design and findings, as most of these studies were conducted not in the indicated population of RIF and possess significant errors leading to retraction in some cases. Lastly, ensuring proper protocol compliance is necessary to achieve superior clinical outcomes in RIF patients. The ERA Insight Hub offers resources for clinicians and patients to deliver the best results. So with that said, I'm going to invite our host and panelists back so we can have a discussion. First, I want to introduce some case reports specific to both physicians, which I've had the pleasure of working with both of them for many years. And these are just some outstanding cases that stick out in my mind. So again, thank you for joining us today. I will review these quick case reports, and then we'll go into our discussion. So starting with Dr. Aimee, I thought this was really interesting and especially tied in with the recent RCT looking specifically at advanced maternal age patients. This is one question we get, is that maybe if a patient doesn't have a history of RIF, but only one autologous embryo left or one opportunity left for a transfer, should they consider ERA? And this is one case that came to mind. This was a patient of 44 years old, undergoing their first IVF cycle. She only had one autologous euploid blastocyst available for transfer, and ERA was performed to ensure transfer into a receptive endometrium. Receptivity was actually found after 6 days of progesterone, so about 136 hours, utilizing an HRT cycle. And fortunately, the PET resulted in a healthy live birth for this patient. In the case with Dr. Glassner, he too had a similar scenario with a patient of advanced maternal age, this time 40 years old, but again, only had one euploid autologous embryo frozen and available for transfer. Now, this patient had undergone 5 previous ERA mock cycles at another clinic before transferring care to Dr. Glassner at Main Line Fertility. And at that time, she wanted to ensure that she was transferring at optimal time of implantation. So this patient actually underwent a total of 9 ERAs, which is not common at all, but we have a very special observation here that we noticed with her. In this case, a very narrow window of implantation, in which was less than 12 hours in duration. So you can see here at 156 hours, she received an early receptive result, which according to the algorithm would say transfer 12 hours later. So this would be at approximately 168, but at around 170 was her sixth biopsy was late receptive, indicating transfer 12 hours sooner. So we knew that her window of implantation lied within this time. With that said, the patient was adamant to receive a receptive result before transferring her embryo, so underwent subsequent biopsies in which receptivity was ultimately found at 164 hours. Now, knowing that this patient had a very narrow window of implantation, our endometrial team actually recommended that she transfer here around 158 hours of progesterone exposure, so just prior to the window of implantation. The reason for this is because we wanted to ensure that the blastocyst had enough time to undergo the complete implantation process while the endometrium was receptive. So again, the window of implantation was open less than 12 hours. A more personalized embryo transfer recommendation was provided. And her only remaining autologous euploid embryo was transferred at 158 hours and 25 minutes, which resulted in the live birth of a healthy baby girl. So these are some of the, like I said, cases that stick out in my mind, and to think if ERA wasn't performed in this case, because for example, in this particular case, not only did she have a very narrow window of implantation, but we saw a displacement of 2 days, so needing an additional 48 hours of progesterone essentially before even reaching a receptive phenotype. And those are the cases that stick out, wondering what would have happened if we didn't do ERA. So now that I have presented and talked quite a bit, I want to get to our discussion with our panelists, which I think is why we're all here today. So let's go ahead, and I have some questions that I want to review, and then we'll open up to the audience, as I'm sure there are questions we are receiving for any of us here. So the first question I have, so again, thank you for joining us today. Where do you see the value of ERA in your practice? So I don't know who wants to go first.
Dr. Aimee, you want to kick off?
Oh, sure. I mean, I think, you know, in recurrent implantation issue patients, I hate to use the word F word, because failure just seems like something that people get labeled with, and I don't like, this is my style. So in patients with recurrent implantation issues, I think when they have good quality embryos just aren't working, I think that that's something that I do for patients. It is part of my menu. I have one of my many acronyms is the Egg Whisperer Diet. So that's my recipe for success, so to speak. The D stands for diagnosis, I is IVF, the E is embryo transfer preparation and endometrial receptivity, and the T is transfer. And so I feel like it's only fair, especially in the case that you presented of mine, Tiffany, where a patient's done 6-7 cycles and finally has one euploid at 44, that she's presented everything on her menu, and then she gets to choose whether this is something that she would like to do or not. I think it's unfair if a transfer fails to then bring it up to a patient, because then they get really angry. So I always present it to my patients as part of my, you know, it's not necessarily something that I tell them they have to do, but I want them to know my experience with the test, how I think it could help them. And I think it's really important as doctors for us to talk to our patients about what we would do if their transfer didn't work, so that they know that in advance, so that they have the option of potentially doing those things up front. So that's another patient population that I do it in, which means any patient of mine who wants to do it. The other group is older patients who are using donor egg, the menopausal patient who's 48, 50, 52. Yes, I do have patients who are 52 years old and pregnant with donor eggs. And I would say that it's really interesting, and it would be interesting to look at the data from my practice, but I think that a lot of them have windows that are not typical for me. So they're either pre-receptive. A lot of them are mostly pre-receptive and not post. So I'm using maybe 24 to 36 hours more in terms of when I start the progesterone compared to, let's say, the patients who are under 45. So I think that's a really good patient population. I think we think of, they have so many embryos, they're all donor eggs, but, most of these patients, when they get to this point, I mean, all of our patients, they want that first transfer to work. I don't like to do it personally in patients who have a thin lining. I'm just worried about damaging the lining. But I do know that there are doctors that, still do it and they see great results. That's just one patient population where I'm a little bit careful about doing it in. And just to note, I think I'm one of the first patients in the country to ever do the ERA. I think it was even before 2011, before it was even clinically available. I saw some sort of press release before ASRM. That patient had done 5 transfers. Her doctor had told her that she needs to use a surrogate. She came to me and her window was like the shortest window I'd ever seen in my life. I made her do it again so that I would just believe it. It was like 4 days of progesterone, something like that I would have never done for a blast. And we didn't believe it because it was my first time doing the test and she was already told that she needed to use a surrogate. I transferred 2 embryos, which I would normally never do, and she got pregnant and had twins. So I'm just going to throw that out there. I know it's hard to believe I've been in practice that long, but I think this test is very useful for a lot of patients who've been through a lot.
Yeah.
Yeah, go ahead.
I know you mentioned AMA, and we've seen, and a lot of other physicians bring up that they see a higher rate of displacement in advanced maternal age patients. And we weren't sure, is it because the advanced maternal age patients are a reflection of the recurrent implantation failure, like or issues years after years, or is it a true effect of endometrial aging? And that's what we're trying to understand now. But we see the same trend where advanced maternal age patients tend to have a higher rate of displacement than younger patients. Sorry, Dr. Glassner.
Yeah, so I've been using ERA since its inception with iGenomics, and I remember when it was first around for the first 6 months. Every time we did a test, we would repeat it with the necessary recommendations, and after 6 months, they felt that the test was valid enough that you did not need to do the repeat, despite my patient who, insisted on a total of 8 or 9 ERAs. I wasn't going to argue with her. That was an argument I was not going to win. But I actually mention it to all of my patients going through IVF because, your patients don't want surprises. And if you have a patient who goes through IVF and they don't have a euploid, they only have aneuploid, they finally get their euploid and they're excited to go to transfer. And then you're telling them about this test and they're going to lose, a month and a couple $1,000. And they're like, why didn't you tell me about this test ahead of time? So when I'm counseling my patients for IVF, I tell them that there's a number of touch points we're going to have. One is now we're putting together a protocol. The other is once we see the blastocyst number, and then once we get the euploid rate. And at that juncture, many times we'll take a beat and we'll say, all right, you only have 1 embryo. Do we want to risk it all and find out that you really were a patient with would be a RIF situation, or do we do the testing just in case? So I offer it to all of my patients. Somebody comes out of a cycle with 6 euploid embryos and they want to go to transfer. I make sure they're aware of what we'll do if it fails, and that would be doing the ERA. But my average new patient's 38, and 38, if we're lucky, we'll get a euploid embryo from a cycle, and at that point they're wanting to do whatever testing's available. The other thing that you do see, and Dr. Aimee, address this, if you don't mention it, if you don't let the patients be partners in this decision-making process, you do your transfer, it didn't work, you're doing your post-mortem with them, and you tell them about the ERA, they're like, why didn't I hear about this now? I just blew 20 grand on a cycle and for drugs, treatment, genetic testing, and there was a $1,500 test that might have changed the outcome. And then you run the test and it turns out they find something, then they're really pissed that they weren't given the option to accept doing the test or not. And, there's a practice in Philadelphia, they don't talk to their patients about it at all till they failed 3 transfers. Well, when I see those patients and they're coming in to do the ERA, they don't understand why it hasn't been at least offered to them before the first transfers so that they can make an educated decision. These embryos are valuable, and one failed implantation is one too many. But again, I think, as we all realize, we're just helping to shepherd our patients from one point to the other, and we're supposed to give them the ability to make their own decisions and give them the information, and how they play it is their decision.
And then I'll add, and Dr. Glassner, you probably hear this too from other clinics in your area, where patients are being told that the ERA causes harm and your chances of pregnancy if you do it are lower. And I just don't see that in my practice at all. So I just think that that's the easy way out of not doing a test that could potentially help your patients and taking extra time. And that's just not the right way of analyzing some, the study that Tiffany shared with us. I don't see in any way, shape, or form how the ERA can cause harm, unless people are, spending 45 minutes doing a biopsy and damaging the uterine lining potentially, which right. We're not doing.
These are well-informed, intelligent patients, and they're online, they're reading about this. And if you don't bring it up, if you don't mention it, they're wondering why you aren't and why it wasn't offered. And I just think, again, if for me, it's part of the conversation when I'm talking about IVF, that there's further testing that we might do to assess implantation once we see what we have in terms of euploid numbers. And they're educated people, let them make the decision about whether they want to do it or not.
Yeah, those are all really good points. And I think our patients are becoming more educated now that, with social media. Dr. Aimee, you're huge on social media, so and with your Egg Whisperer podcast, so patients are getting informed. It's not, 20 years ago we didn't have the resources out there for patients to learn. But as far as what you were saying with harm, the harm that I see is when the ERA test is not performed correctly, and that's leading to these negative publications, because we've done, a reanalysis of some of the data that was published by other groups. And we see that they had a 30–40% dropout rate in one of our studies because of improper or no protocol compliance. So they would do the mock cycle in a natural and then transfer an HRT, which we know the results are not reproducible. So the harm comes from not performing the test properly. And I think, both of we've pulled your data. Lauren has actually gone in person and has done a data review, and you both have amazing results when it comes to ERA. And we always think it's funny that the physicians willing to share the data are the ones that are doing it right and that have really good results. So, it's definitely a disservice to patients if it's not performed correctly and if it's not offered to them, because patients want to feel empowered to make their IVF journey their own. And I think that's the epitome of personalized medicine.
So a lot of times as clinicians, we're hesitant to do something because we're not familiar with it. And, iGenomics has been incredible in terms of educating staff and really holding our hands through their evaluation. And they're there for the patients also to talk to them. So, when you think about putting your toe in the water, it's not like you're going to do it blindly. There's everything to be gained and nothing to be lost by it.
Yeah, I appreciate that. We definitely want to support, physicians and patients, and that's why we brought Lauren on 2 years ago as an IVF nurse. And when I say, ERA works and it can do wonders, and my goal in life is to optimize IVF as much as I can for patients, which is why I basically have a PhD in ERA. So we know it works, and it works well when conducted properly.
Yeah, I think you gotta get those messages out more about, because it's on Reddit. It's patients are posting. I continue to share all my podcasts, my articles on the ERA test interviews that we've done. And then I have people that post and say, like, how do you still recommend the ERA when it's been proven to be harmful? And I'm like, you guys, it just hasn't. Yeah.
Exactly. It was one of those things where I think things may have been blindly followed without actually getting to the bottom of it first. So we know that it can make a profound difference in people's lives. And, being that up to 50% of patients can drop out by the third IVF cycle, when it can just be a minor shift in when to transfer, that's a difference between going home with no baby and having a baby, plus more in the future. So that's always important to consider. So you both mentioned the population. So you offer it to everyone, Dr. Glassner, and Dr. Aimee, you inform your patients of that this test exists and whether they want to do it or not. You mentioned advanced maternal age. Are there any other specific populations? So we know that ERA, although it's not directly indicated, but can be beneficial, for example, for patients with BMIs over than 30, as we see a significant increase in displacement of implantation, or even patients with thin linings. For example, we just had presented an oral abstract at ESHRA showing ERA and thin linings. Any other patient populations that you consider?
I think the unexplained infertility patient, the patient who comes in, their workup's been completely normal. They do IVF and they have a kick-ass cycle, and they have sperm does great, eggs do great. They have, 7 blastocysts and 6 out of 7 are normal. So you're sitting back and saying, all right, why aren't they getting pregnant? Because obviously there's no egg issue, there's no sperm issue, there's nothing anatomic going on. And so, the luteal phase has always been the big question. And going back when I was a fellow in the 80s, and we were doing luteal phase, biopsies, and it's always been an enigma. And, I do think that one day a great study would be when a patient's coming through in their initial diagnostic workup, doing an ERA based on a natural surge and seeing how that correlates with continued failure with OI cycles, and then where you'll end up with IVF. And I think if it could be demonstrated that a patient is out of phase in a natural cycle, there you have your diagnosis of an unexplained infertility that you otherwise wouldn't be doing. We're not doing these luteal phase biopsies anymore, and looking to see for luteal maturation. So to me, the patient who comes in who's unexplained and they have a great IVF cycle, something's going on, and it's got to be the luteal phase.
That's a really good point. I just had a 35-year-old. She had a gorgeous cycle, has been trying for 3 years. And I think I got like 7 euploids on her. And when I present her options and talking to her tomorrow, I'm going to bring that up, because I don't think that I would have brought that up otherwise. So that's a good point to just suggest in patients who you don't really know why they have a gorgeous cycle, they might benefit from the ERA, even if they have multiple euploids, just to give them the best chance of first cycle success.
Yeah, you have to imagine they've had multiple situations where they've fertilized and not implanted if their eggs and sperm came out so well and everything else has been normal in the workup.
Yeah.
May I also suggest Emma in that case?
Yes.
Oh, I
endometrial microbiome testing.
Oh,
and
yeah.
get her from Alice too.
Everybody. Yeah, I checked the blood for everybody. That's a given.
It's the trio all the way through. Yeah.
Yeah, definitely.
So one drawback that we've received is that with the ERA, you need an additional mock cycle. The patient needs to undergo an invasive endometrial biopsy. When you're talking with your patients, how do you explain the benefits of ERA and that they outweigh maybe the unfavorable considerations associated with the ERA test?
Well, for me, if you think about when we get genetic testing results back, it's after the period start. So they're waiting anyways a cycle to get their results. So it's the perfect opportunity to use that cycle to learn about their lining, especially in patients who've already banked embryos. No matter what the outcome is, you're going to move forward with the transfer. So typically what I'll do is I'll put them on birth control pills when their period starts, wait to get the results, and then present the options. But sometimes we already know that we're going to go right into an ERA cycle. So I don't really think that it's a waste of time. I think it's an investment of time that is well worth it. And the procedure, it's a gentle biopsy. And the way I do it is I give everyone a Tylenol with codeine and a Valium, so they love me when I do the procedure. And most of them have no pain. They have to have a full stomach, a full bladder, and a driver. And, I can get in. I do abdominal ultrasound guidance for some of them. And so I literally have them count to 5 and I'm done. But I hear these horror stories of patients who are, the biopsy is taking 30 minutes and 40, it's an empty bladder. No one puts an ultrasound probe on their belly. But if you just follow the simple things that I do, almost every single ERA test, the procedure itself will be very smooth and the patient experience will be good. Probably like 10% of my patients decline the stronger pain meds and they're fine on Motrin, especially patients who've already had a baby before. But I think in nulliparous patients, it's a very kind thing to do when you're offering a patient a procedure that's going to cause them pain, is to give them strong pain medication, because that's just, I think, the right thing to do.
Yeah, I think it always gets back to managing expectations. And if a patient knows up front that after the retrieval, there's this possibility of a diagnostic month, and they'll take a beat and, spend the 3 weeks to get the biopsy. And to Dr. Aimee's point, you're usually getting their menses before they have gotten their results back. So you're not heading into a transfer cycle unless you're holding them off on the pill. But, a 40-year-old who wants 2 kids, you're managing expectations. You're telling them they're going to need probably more than one IVF cycle. They may need 2, they may need 3. You're telling them that somewhere along the line, we're going to do some diagnostic work. So as long as the patients are aware of it, it's not a tough conversation, especially when it's something that they have heard a couple months back. You're not springing it on them and they're like, well, how did this come out of left field? So if it's part of the dialogue, no one's going to balk at another month, especially with what all these patients have been through to get to that point. And if it could mean optimizing implantation, nobody balks at it.
I think that's another important consideration. And, I've always been a huge proponent of that, is that you're not just planning for one baby in a lot of cases, you're planning for multiple. So you have to look at the bigger picture. And like you said, Dr. Aimee, it's an investment into, you're making an investment when you choose ERA. But I think patients come through with the perception that, it's going to be one IVF cycle and it's going to work immediately. And then when they only come out on the other side with one U-put embryo available for transfer, the story changes a bit. So I think laying the whole story out and understanding the patient's goals for their family planning is imperative. So, for sure that plays into it. So as I mentioned before, both of you've had your ERA data reviewed by Lauren directly, and both of you have amazing patient results using ERA. What other tips or advice do you have, for other clinicians to realize the same successes?
I think he said it all. Set expectations early. Make sure you're talking about what the steps are. I already mentioned the egg whisperer diet, but I talked about we're going to do things in 4 stages. Stage 1 when I need a patient's diagnostics, and IVF, and then transfer prep, then transfer. So they kind of know that I'm not springing something on them that they don't already know from the beginning. And I think it's important to combine the ERA with everything else, like the microbiome. So I think I don't want to say the word useless, but I think it's not a good use of a patient's time to only do the ERA and not do the Emma and Alice test as well. And then, your patients are going to feel reassured that you're leaving no stone unturned. So if they know the why behind each step, then it will make them feel really hopeful that they are going into their transfer fully informed. So if the transfer doesn't work, they're not going to have regret. They're not going to wish they had done additional testing, because you've really done your very best. And when you do that post transfer call, if the transfer test unfortunately comes back negative, you can then have that conversation with your patient that, we did everything possible. It was not something that we could have controlled or changed. It was really that embryo. And what we learned is that embryo didn't have what it takes. And we did everything that we could to make sure that your uterus was perfect.
Right. Yeah, if I'm doing the ERA, I obviously do the trio because it's just another couple $100 and you're doing the biopsy anyway. I also am a believer in the receptiva. And the same time that I'm doing the biopsy for the trio, I'll send some of the sample to assess whether the receptiva is a factor. And I do more than dabble in reproductive immunology, and I use the PregMune testing to look for compatibility issues, autoimmune issues. But again, I've been in this field, unfortunately, for about 35 years, and probably 70% of the patients I see have failed IVF elsewhere. So it's not the slam dunks that I wish I could do. But again, I mentioned the trio, I mentioned the receptiva, I mentioned PregMune up front to all of the patients, so they know that there's other things out there. And same thing, if you do the trio and then they walk in and they say, well, what about natural killer cells and HLA compatibility. After the fact is not the time to say, well, that may be a factor. Some people buy into it, some people don't. So again, it's making sure you're a partner with the patients and making sure that later on you're not going to bring something up that they wish you had offered at the beginning. And thinking outside the box, I mean, you know, we've been stuck since PGS was done. We've sort of been stuck with the same pregnancy result, and obviously there's more to it. We're putting a euploid embryo in and it's not working. And whether it's ERA, Aimee, Alice, receptiva, or, you know, reproductive immunology, there's a lot that we're still missing. So it's just realizing that, you know, we got to think outside the box for these patients.
And what do you say to patients? So I do receptive as well, and I offer Pregnum too. But so many patients are asking their primary doctors, because I do a lot of second opinion consults, and I support patients with these tests if their primary clinic won't do it, and then I support them with their transfer and help them advocate with that clinic with the changes. But the clinic will still say things like, you know, they'll make fun of me for offering Pregnum, or they'll say things like endometriosis doesn't impact implantation. I'm curious, what do you say to how do you have that conversation with the patient to make them feel confident that the tests that they're doing have value? I mean, I think when we've done this for, you know, 35 years or like 20 years, like I have, there comes that level of trust that patients have with you because of the thousands of patients that we've seen. But I'm just curious, are there some phrases that we can learn from? Because I know other docs who are listening to this, it would be helpful for them to hear.
Yeah, I mean, you know, when my wife needed IVF, I did her IVF. I did my daughter's IVF, my daughter-in-law's IVF. And when I'm talking to a patient, I tell them, this is what I would do if you were my kid. And it's as simple as that. And you know, again, when I have the majority of my patients having failed IVF elsewhere, they're coming looking for what's being missed. So it's a much easier conversation. And when you know, and I don't strong arm them. I say, go to the Pregnum site, go to the iGenomics site, read about the test, see if it rings true to you. And, you know, when I have somebody with repeated implantation failures, you know, I'll give them percentages. You know, I think there's at least a 40% chance your ERA is out of phase. I think there's a 70% chance Pregnum is going to come up hot for something. And it's really a money decision. And, you know, Pregnum runs what, $2,000. The trio and receptiva together runs $2,000. So you're at $4,000 with all the testing. What they do with the information is up to them. If they say, look, I don't want to do, you know, immunoglobulin, or I don't want to mess with the timing. I had one patient who was 96 hours out for ERA. And, you know, so patients will decide what they do with the information. But what I have found for these patients who feel powerless and they feel like they have no control, when they get a test result that says, oh shit, there's something wrong and it's actionable, they feel empowered, because they're not just doing the same thing, rinse and repeat. And you see it. You see a patient comes in, they've done 5 ERT cycles, nothing's different, and they're 5 embryos down. So patients are empowered with maybe getting some answers when they've not been offered answers before. And so they, you know, they're, as long as the money makes sense, they're up for it.
Now I want to see the Netflix show of you and your kids doing their IVF, because that would be pretty fun to hear their perspective about their dad helping them have a baby. Yeah. That's pretty special, I got to tell you. That's cool.
One of my grandsons that was from IVF lives next door to me, and they named him after my father, which is very nice. Yeah,
that's a very special story.
Well, I think you know, both of you represent thinking outside the box, and there's a reason, you know, that patients come to you when they've exhausted, you know, everything. So Dr. Aimee, I see patients all the time on Instagram flying all over the world to come see you. Dr. Glassner, like I said, you were the first NGS baby worldwide back in 2013, and one of the first to do egg freezing back in the early 2000s before anyone even knew how to do it. But I think the point you made is that a lot of times you'll see these patients who come to you and they'll just keep doing the same thing over and over. And in fact, just a year or so ago, we were at a talk with one physician, and they said, just keep transferring euploid embryos. Eventually it'll work. Just keep doing the same thing over. It's like, okay, well, that's great if you have unlimited amount of time, money, and physiological, you know, physical and psychological stress to give. but that's not, you know, it's not realistic for most patients. Most patients are having 1 or 2 mortgages out on their house to afford to have a baby. So undergoing multiple fresh IVF cycles with PGTA and failure after failure is not going to work.
The other thing that I think is really important as clinicians, we've all had that moment in time when you've been doing something with a patient and they go to another physician for a second opinion, and then they come back and say, well, they talked about this, why didn't you ever mention it to me? And, you know, the trio's out there and people are aware of it. And, you know, there's other reproductive endocrinologists and fertility docs in the town. And if you don't mention it so a patient can make an educated decision, and they go across to your competitor for what it's worth, and they offer it, they perform it, they get pregnant, well, shit, that patient's online telling everyone how you didn't even talk about this test, and they went across the street and now they're not 5 months pregnant. And I think you should be practicing in a defensive way, but it's really just being transparent with the patients that they're aware of all these things, whether it's trio, receptive, or pregmune, because someone's going to mention it to them. And if you never mentioned it, it's one thing. If you mention it and they said no, there's not as much egg on your face, no pun intended, in an IVF conversation.
Well, that was a really great conversation, and I've been looking forward to this webinar for quite a while because I admire both of you, and I've worked for a long time with both of you, so it was great to have you. Lauren, I know we're running a little bit over. We haven't hit the end mark yet, but do we have any questions or any good ones that you see that might be good to ask?
Yeah, absolutely. So one question we have, some other physicians who have utilized ERA in their practice and have found no benefit for their patients. Can you please discuss what is possibly different in their practice from yours, which could be the cause of a much different outcome?
I mean, I would say they just haven't done enough tests. I mean, I don't expect every patient to have a displaced window. I tell patients maybe 1 out of 10, I'll actually get a displaced window from what I typically do. But that one patient will be extremely grateful that we did the test, and the other 9 will be very grateful that they have a receptive result and can go into their transfer feeling really great about it. So I would just say to that person, maybe they just haven't done enough tests. I mean, we probably do. I'm not going to say how many transfers you do a year. I mean, it's under 1,000, but it's over 300, right? Transfers that I do. And not everybody, but I do hundreds of ERAs a year.
And I think a lot of it is patient population. I mean, you know, as you drift further down south, you're going to have a younger patient population. So you're not going to run into the AMA issue. You're not going to necessarily be dealing with, you know, again, my average new patient's 38 and more than half of them failed IVF elsewhere. I'm going to find something because something's going on. But if you have a relatively innocuous patient population, you're probably going to have a lot of positive results. But to Dr. Aimee's point, the one that needs it, that's one too many that you would have missed. So if you run it and the patient knows, hey, if it's normal, they have the reassurance that everything is best as we know in 2025 is optimized, and you can move forward with that knowledge. And if it doesn't work, then you can start going down the rabbit hole of reproductive immunology and looking for systemic issues, again, having mentioned it to the patient before. So my normal rhythm is, and it was funny, one of the first patients that gave me pause was a physician from Wisconsin who was 43. She did 5 IVFs. She had 1 euploid embryo. And she said, do every test that's known in this era before you put that 1 embryo back, because I got 1 shot on goal and I don't want to find out afterwards that, oh yeah, there was another test. So this patient who had never tried to get pregnant, she was using a sperm donor, but she had been through 5 cycles and had 1 euploid embryo. She was realistic. There was no reason to suspect she had an implantation issue, but she came up hot with the ERA. She came up hot with a protein S deficiency, and she ended up being pregnant. And you know, just because she was medically educated, she knew enough to say, run all the tests. Well, again, I think all the patients should be aware of what's out there, what's in the menu, to use a term that Dr. Aimee suggested. And, you know, if I have a patient with 4 euploid embryos, well, you know, we'll do the ERA and the M analysis. Then a negative, then I'll probably run the Pregmune. If they only have one embryo, I'll talk about running all of them, because I don't know if there's a conversation tomorrow.
I also want to mention the importance of proper protocol compliance as well when patients are either being prepared for the biopsy or how do they utilize those ERA results to then transfer that embryo. I wanted to ask how you manage patients in your practice that are either transferring care with ERA results from a different practice, or if patients are coming back to you for a secondary pregnancy, how do you manage those patients who had a previous ERA?
Secondary pregnancy, I tell them that things will change in their uterus, and I suggest repeating the testing. And if they have an abundant number of embryos, sure, you can follow the same protocol, but I let them know that their uterus is different now. It's been through a pregnancy, and and I have seen divergent results where they were pre-receptive before, now they're receptive. Patients coming with an ERA from a prior center, I will offer to follow the protocol as best as we can and make the adjustments accordingly. I don't necessarily require them to go through another biopsy with me. If the protocol that was used to get to that point doesn't make sense to me, I'll talk about the benefits of doing another biopsy.
Same exact thing, what he said.
Well, we're getting close to the top of the hour. As much as I want to keep this conversation going, I know Dr. Glassner and Dr. Aimee are very busy. So I guess we'll go ahead and close it out. If there's any other questions, like Lauren said in the beginning, we can go ahead and address those, follow up directly with you after the webinar today. But on my end, I want to thank Dr. Aimee and Dr. Glassner for joining us tonight. I really enjoyed this conversation, and hopefully you come back again and have another conversation. Maybe we can talk about Emma and Alice next time. So Lauren, I'm going to hand it off to you to close it out.
Yes, thank you as well for being here. We really appreciate your insights. I do want to mention that we are now offering an endometrial evaluation program for clinics who are using ERA currently, or maybe they're not using ERA as much anymore. And we want to encourage those clinics to take this opportunity to experience a retraining with proper protocol compliance for ERA, how you can best optimize the use of the test when indicated for those patients with recurrent implantation issues. And with that program would allow us to retrain your clinic and your staff for those optimal outcomes. And then we would just evaluate those patient outcomes to show the improved pregnancy outcomes for your patients with the indicated population, to see how those patients resulted after using ERA. And so if you're interested in learning more about that program, please reach out to us. We'll be more than happy to get that virtual session scheduled for you, so that you can utilize 5 ERA or endometrio cycles for those patients. So please take advantage of this opportunity. You can scan the QR code on the screen for more information, and we look forward to working alongside with you. Thank you again.
I just want to mention one other thing, and I think if you do start to incorporate it into your practice, you'll be surprised how many patients say, I've heard of it. And the patients aren't bringing it up, but they've actually heard of it, and they're almost waiting for you to talk about it. So patients are coming in really educated, and you might as well make them your partner in their decisions.
Agreed. Well, thank you again, and thank you for all of our attendees who joined us tonight. And I hope everyone has a great afternoon and a great Tuesday evening.
Thank you, Tiffany.
Thanks.
Take care.